Thank you. Good morning to everyone. Thanks to Dr. GVK sir and the organizing committee for this wonderful opportunity to be with you. And I'm just going to trace history of SGLT2 inhibitors so that we'll know how this drug class evolved. It all started in this Belgian garden, apple garden. Jean-Baptiste van Mons was a Belgian chemist, agronomist and pomologist. Pomologist is the one who studies fruits. So he was credited with development of wonderful varieties of European pears. He had a large apple garden and the trees were withering away. So he called two of his assistants, gave them a lot of apple box and asked them to displant all the old ones and replant new box. So these two assistants, Laurent de Koninck and Jean Servin Stas, finished the task, but they had remaining box in their hand. And then they returned to the lab with the box and analyzed the box, found that these boxes contained a compound called fluorescein. And they published this in 1835. So for 50 years, it went unnoticed until Professor von Mering, who's the head of the Department of Biochemistry, University of Strasbourg, Germany. Actually, he was the one who did the famous dog experiment with Oskar Minkowski to find that the pancreas was the seat of diabetes. And he is considered the godfather of SGLT2 inhibitors. Why? Because he had the knack of administering various compounds to animals and document the physiological effects it caused meticulously. Fluorescein happened to be one of the compounds administered by him to the dogs, and he documented glycosuria in dogs in 1836. And he had the audacity of administering fluorescein in people with diabetes, and again he documented glycosuria in 1887, the next year. And also he detected ketones in urine when he induced glycosuria with fluorescein. And all these publications are there, but again went unnoticed for another 101 years. And Oskar Minkowski, actually the physician who worked with von Mering, he developed interest in fluorescein because he knew that fluorescein causes glycosuria and they were already doing the dog experiments. What he did nephrectomy after administering fluorescein and found that the blood glucose did not lower after doing nephrectomy. So he proved that fluorescein acts mainly in the kidneys. And 101 years later, SGLT2 gene was decoded, especially in the people with primary renal glycosuria. And this stimulated further interest in research. And the first molecule, there were three candidate molecules, dapagliflozin, CANA, and EMPA. DAPA got approved in November 12 by European Medical Agency. That was the first approval given by this by an agency for this class. But the approval journey was not very smooth. In fact, when the data and efficacy data was given to US FDA regarding dapagliflozin by this group after conducting phase 3 trials, the endocrinology committee actually they voted against its approval because of some signals about bladder cancer. So their main concern was probably dapagliflozin might be increasing the risk of bladder cancer. So it took 2 years for these companies to provide additional data from ongoing trials to prove that it was not the case. Then this US FDA mandate, 2008 mandate, to prove that all glucose lowering medications need to prove their cardiovascular safety. Actually, this mandate happened because of the rosiglitazone controversy. So naturally, this class had to undergo this cardiovascular safety outcome trial. And EMPA-REG was the first outcome trial which was conducted to prove that it is cardiovascularly safe. So this trial enrolled participants with established cardiovascular disease. That means all the participants in this trial had established cardiovascular disease, and both the doses, 10 and 25 milligram, was compared to placebo, and they were followed up. And amazingly, actually it was a surprise to the research community. Empagliflozin led to early and sustained reduction in cardiovascular death. If you look at the global study population, there was a 38% relative risk reduction in CV death. And then they did a subgroup analysis where they could prove that Asians did better. Actually, there was a 56% relative risk reduction in CV death among the Asian patients. This proves that the Asians respond better to this class like DPP-4 inhibitors than the global population. And with this robust data, it became the first ever drug, diabetes drug, to get approved for a clinical outcome indication. It's not for glycemic reduction or anything. It got approved to reduce cardiovascular death in adults with type 2 diabetes. And the same trial had a lot of other secondary endpoints like hospitalization for heart failure, death due to heart failure, sudden death, presumed CV death and all. So all factors, actually parameters, showed significant improvement, and it was time to design dedicated cardiovascular trials. If you look at the cardiac outcomes in all the three major SGLT2 inhibitor cardiovascular outcome trials, you can see there was some difference, like the hospitalization for heart failure and CV death reduction was better with EMPA-REG than the other two, CANVAS and declatimi. That was because of the differences in participant characteristics. EMPA-REG outcome trial enrolled patients with advanced heart disease, whereas the other trials had majority of the patients with cardiovascular risk factors. And this trial, HFRF, this DAPA-HF trial was conducted in patients with heart failure with reduced ejection fraction. Actually, they have to prove that in heart failure patients, by administering this drug early on, they reduce the primary outcome. So this trial was designed to prove that it is effective in patients with reduced ejection fraction and heart failure. So there was a 26% risk reduction, and you look at the number needed to treat, it was only 21. And what more, it improved the physical function and quality of life also. Any patient with heart failure, they even find difficult to walk or climb stairs. It's all about the quality of life for them, and every day their quality improved after getting this treatment. And the benefits occurred as early as day 28. You can see the Kaplan-Meier curves separating quite early on. Within 2 weeks, you can see the separation of the curves. And the primary endpoint was statistically significant as early as day 28. And then the next logical step is to see whether this class will prove beneficial to the patients, often neglected group of patients with preserved ejection fraction. So this trial was designed to see whether patients with heart failure but preserved ejection fraction will get the same kind of benefit. And you can see again a 21% risk reduction of the primary endpoint, and number needed to treat was only 31. Again, it proved beneficial. And what about patients without diabetes? Whether heart failure patients with diabetes and without diabetes fare equally well? Yes, these trials luckily had patients without diabetes, and for them also the benefits were similar. And this is a whole history of trials with patients with heart failure. You can see whether they got diabetes or non-diabetic, or whether they are in the early stage of heart failure or advanced stage, whether their ejection fraction is low, mid-range or normal, whatever the stage they are in, it is going to be effective. And then the next question came up, whether it is for outpatients only. What will happen if you administer this class to the patients who got admitted with acute heart failure inside the hospital? Then they did some trials. Of course, DELIVER included some patients with heart failure who were admitted in the hospital, but it was not a dedicated in-house hospital trial. But then there were other trials which looked at whether by starting this drug around the time of discharge or even within 24 hours after admission will provide the same benefit. So these trials proved that these this drug class will will provide the necessary benefit for such patients, even if started around the time of admission. So this inpatient guideline-directed medical treatment sequencing was formulated with the robust evidence, and now this is the treatment paradigm suggested. We have to start RNA beta blocker within 24 hours, and then add MRA, and then SGLT2 before discharging the patient. Of course, we need to do a close follow-up to maximally titrate to tolerated doses, and then watch BP, heart rate, potassium, and creatinine levels. So moving on to CKD. CKD is a marker of mortality in all patients with type 2 diabetes. As the patients develop albuminuria and as their eGFR goes down, naturally their risk of dying is far higher. And diabetic kidney disease is associated with increased risk of CV events. You can see in this graph, as the baseline eGFR goes down, the risk of CV death is very high. And if the albuminuria also gets worsened, which is a marker for damage, again, the risk of dying due to CV event is very high. And what more, by having diabetic kidney disease, patients with diabetes, they have an increased risk of getting admitted with heart failure. So the risk for hospitalization due to heart failure increases as the eGFR goes down. And again, the same applies to albuminuria also. Increasing categories of albuminuria, the risk for heart failure increases. So luckily, all the CVOTs had some renal endpoints also. So empiric, canvas, as well as declaratomy, they had secondary renal endpoints, and those renal endpoints, they could observe significant reduction in those patients who got exposed to SGLT2 inhibitors. So naturally, they had to devise some dedicated CKD trials like CREDENCE, DAPA-CKD, and EMPA-Kidney. All these trials were designed to address whether this class, if started early on in patients with diabetic kidney disease, will provide the CV benefit as well as the risk, reduce the risk of dying due to cardiovascular morbidity. So these trials were so nicely designed that they enrolled different categories of CKD patients. If you look at the KDIGO heat map, these participants belong to different columns of the CKD KDIGO heat map. And this is a primary composite outcome in DAPA-CKD. There was a 39% relative risk reduction of the primary endpoint, that is sustained, a composite of sustained more than 50% decline of eGFR, ESKD, renal or CV death. And there was a mortality benefit also. And if you look at the patients with diabetes and patients without type 2 diabetes, you can see even the reduction in patients without diabetes was even better. So that means any type of kidney disease, whether they got diabetic kidney disease or it's a non-diabetic kidney disease, this drug class was proven very effective. So that made the nephrologists to grab this molecule because they were without any proper treatment apart from RAS inhibition, glycemic control, and good BP management. This was a drug godsend for them. And finally, if you start this class quite early on versus delay it for some time, what happens? This is a mathematical model using the CREDENCE data. Actually, the typical CREDENCE patient, the mean age was around 63 years. The eGFR at baseline was 56 years. And if they were continued only on RAS blockers, the eGFR decline will be 4.6 ml per year, and they will reach 10 ml of eGFR in the next 10 years. But if you start SGLT2 inhibitor on top of this RAS inhibition, then the eGFR decline will be slowed down to 1.85 ml per year, and they will reach the end-stage renal disease, necessitating the renal replacement only after 15 years. So you get additional 15 years of freedom from having a dialysis. So it's like a tortoise and hare story. And these are the data comparing all the glucose lowering medications, you can see SGLT2 inhibitors have ticked majority of the boxes which matters to the patient. And the side effects are very minimal and the benefits are many. And these are the truly disease modifying interventions which you have to start early to slow the disease progression, preserve the kidney function, and reduce the CV complications. So there are a lot of data available, emerging data, and the indications are expanding, the contraindications are shrinking. The next logical question is to design a trial to address this question: shouldn't we add SGLT2 inhibitors to our water supply? Thank you.